My name is Bruce Ramshaw. I want to thank SAGES for the invitation to present this talk. My topic is to mesh or not to mesh in the groin. That is the question. But I want to reframe it a little bit to talk about when to mesh and when not to mesh in the groin, and how can we best decide that with our patients, and what's the science behind that. I do have some disclosures. I work with many of the companies that provide hernia-related devices. I'm also a founder and shareholder of CQ Insights, a healthcare data analytics company. Over 20 years ago, two groups of astrophysicists discovered something at about the same time. They discovered that the universe is expanding at an accelerating pace, and that was not what was expected. They both won Nobel Prizes. But we see this in our world in the waves of innovation over time, from the agricultural age to the industrial revolution, and most recently, the information age and the age of networks. We're seeing an increased pace of change, these condensing the time frames of these waves of innovation. But what's this done to our organizations, our companies? The Fortune 500 companies, the lifespan has been decreasing. This increasing pace of change has put strain on our companies and how they're structured. And we've seen this in healthcare as well. With increasing pace of change, we see increasing fragmentation. We see more and more department silos, having more and more struggles with communication and dealing with providing patient care. And with this increasing number of silos and fragmentation, we see a massive increase in bureaucracy. Thousands of % increase in managers and administrators in healthcare with very little comparative increase in healthcare providers, people actually taking care of patients. And at first this makes you kind of angry as a clinician, but I've realized that this is just a natural output of the increasing pace of change in the way our organizations are structured. And that really, we are all in this global healthcare boat together, and we need to learn how to work together for solutions, because we are in an unsustainable global healthcare system right now. Many people know the United States leads the way in per capita spending in healthcare, and that's unsustainable. But not many people realize that all the other developed countries are also on the same path. Their increase in per capita spending is essentially the same slope of increase as ours is in the US. So we're in the lead, but everybody else is following because we're all structured in the same reductionist science type structures, trying to apply the same structural principles to patient care. So why isn't it working? I gave you a little hint. It's because of the scientific principles we're trying to function under. I had to go back to the time of the Renaissance, and that's Isaac Newton, who developed Newtonian physics. And for a couple hundred years, this really benefited our world, led to the Industrial Revolution, many benefits to quality of life from that. But I think we're beginning to realize now that that same concept of reductionist science is hitting the law of diminishing returns. We're not gaining the same advances in quality of life, life expectancy, and we're seeing a lot of the harm and waste using these same reductionist principles. And clearly, specifically to this topic, inguinal hernia repair, should we mesh or not mesh? A reductionist model would want us to have a one-size-fits-all solution, either to use mesh or to not use mesh. And I would propose that our complex biologic reality is our patients are too complex and different. And what we need to understand is that the true definition of standardization is not uniformity. I went to other industries, the textbook of Introduction to Standards and Standardization, and I learned the true definition of standardization is optimal variety. So what we need to learn to do is identify subpopulations and match the optimal treatments, best value treatment for each of these subpopulations. But we can't do this with our traditional reductionist tools. I learned more about this reading the book, The End of Average by Todd Rose. And in it, he talked about the early days of the US Air Force, where planes were crashing every day, not in combat, just in regular exercises. On the worst day, 17 planes crashed, and they couldn't figure out why. And finally, a young engineer discovered the problem. In the early days, as they were constructing the planes, they did dozens of biometric measurements of all the pilots, head circumference, arm length, waist circumference, leg length, and they designed the perfect size cockpit for the average sized pilot. Problem was, there was no average sized pilot, and the pilots fit poorly in the cockpit, and some fit so poorly they couldn't fly the plane without crashing it. And that's when they learn to use adjustable size cockpits and limit the size of pilots. And we have the same problem in healthcare, trying to apply a one-size-fits-all or find out the best mesh with increasing numbers of mesh options and treatment options. And now on top of that is information from lawyers where we're trying to say there's a bad mesh or get the bad mesh off the market. All of these are incomplete concepts, incomplete understanding of biologic reality. And so about 15 years ago, working with a biologic engineer, we began to build a materials characterization lab to learn what actually happens in the body when a hernia mesh is implanted. And we explanted hundreds of meshes trying to learn what actually happened inside the body. We did a variety of ways of analyzing it. One was a compliance test where we pushed the mesh through a slot with constant force and measured the work required to bend the mesh, like a patient bending over to tie their shoes. What we found was something very surprising to me. The pristine mesh out of the package, the number one, had very low work. It went through the slot very easily. But in some patients, mesh taken out of their body, cleaned off of everything human, was very stiff, very tough, very poor compliance, and took thousands of times more work required to bend that mesh. But in other patients, some of them, the work required to push that mesh through the slot was as good or better than out of the package. So this was completely variable. And that biologic variability challenged my brain for a while to understand it. But what doesn't work is trying to do a one-size-fits-all reductionist approach. This is an example of a complex system and attempting to apply something like prospective randomized controlled trials where you try to pull out a variable, test it directly to an outcome measure, and try to prove or disprove a cause and effect. And that would work just fine if three assumptions were met. One, nothing can change. Two, you have to know and control all other variables. And three, the results need to be generalizable to all patients in all local environments. And that's just not the truth. And so we're seeing the impact of this incomplete science today with our pandemic, where we're all kind of isolated, wearing masks. Well, this quote comes from almost 400 years ago from a diary of someone who went through the London plague. And it was the same strategy, because this reductionist science paradigm is what existed then. And unfortunately, that's continuing to be what we rely on today. So we're going to have to do the same management strategies for this pandemic as we did almost 400 years ago. But there is an alternative. Now, I've been a reductionist scientist most of my career, but as I learned the systems and data science principles, I learned that we can't control our biologic reality. And when we try to, we'll definitely have unintentional harm and unintended consequences. Now, this is an illustration to try to present the concepts of systems and data science to a hernia mesh repair, to understand how to identify subpopulations and apply optimal variety to improve outcomes. There are many patient factors and treatment factors. They're constantly changing and they interact. And anytime we do a hernia repair, we have basically three possible outcomes for our patients. It can benefit our patient, which we hope, but it also could contribute to harm and have a complication. Or it could be that we do a hernia repair and the symptoms don't go away. The patient still has pain or discomfort or whatever the symptom was, but they aren't harmed. They don't have a complication, but then it was just wasteful. So what we need to learn to do in applying systems and data science principles is we need to identify the factors, the highest correlated factors to these different outcomes. Identify the factors that are correlated with good outcomes, full return to quality of life. Identify the factors that contribute to a wasteful outcome where the patient doesn't improve, but they're not harmed. But probably most importantly, identify the highest weighted factors to outcomes that are bad outcomes, complications, especially in this case, chronic pain. By doing this and applying the analytical tools appropriately, we can generate algorithms to identify these subpopulations. So what have we done to try to implement this? These are the concepts behind applying a learning healthcare system in each local clinical environment. Now, based on this article, they say the environment required is where learning is perceived as an ethical imperative. It requires a culture characterized by self-reflection, vulnerability, and the willingness to change. These are some things not traditionally associated with the surgeon environment, but I think this is changing. I think we're all learning. To have a learning system, we need to have the mindset of learning and improving rather than trying to prove we're right or prove the way we're doing it is right. So we started this by defining each patient process, in this case hernia processes, and of course we include a patient-doctor relationship. It's very important, but it's incomplete. It's insufficient for a complex biologic process. If we want to improve a complex biologic process, we need a diverse team. And that team can also include a manager, because although we can't control a biologic process, we can manage it, and we can improve the outcomes. We also got input from engineers. That's Sheila Grant, the biologic engineer that helped build the materials lab with me. And we can also get feedback from patients. They have a unique perspective. We also can get feedback from industry, the groups that produce our devices that we use in surgery, and then other specialists. It took us a few years, but we learned the most important thing to measure in terms of outcomes is the value of care we're providing, because if we can't measure the value of care, we can't improve it, meaning we can't predictably decrease costs and improve outcomes. But value measurement is different for different contexts. So in a hernia process, you're going to measure value very differently than a trauma process or a breast cancer process. And it's important to measure the value of the whole process and then apply continuous improvement principles. And this is where the human computing symbiosis comes in. This is really the original intent of artificial intelligence or machine learning applied to a complex biologic process, is requiring a human team to interact with the computing. So the human team identifies what's the most important data to program into the computer. Then the computer can do a variety of analytical and data visualization applications, but that same human team needs to interpret that analysis and apply insight to process improvement attempts. And this is a continuous feedback loop that goes on and on. I'll give you an example from our hernia program. That's our patient care manager, Brandy. And we were, many years ago, one of our early CQI meetings to try to look at our outcomes and try to figure out how to improve them. And we were looking at our complications, and she spoke up and said, you know, those patients with complications, I see a pattern here that they're the same patients that before surgery are expressing anger, unrealistic expectations, other problems that we didn't understand how to define. We certainly weren't measuring them. We decided to measure it in a very subjective term called emotional complexity, high, medium, and low. And several months later, we did our first factor analysis to generate weighted correlations. And I was shocked to see that emotional complexity was the highest modifiable factor correlating to our outcomes. And so in a feedback loop, in an attempt to improve, we brought in some social scientists that helped us develop a more robust measurement tool, where we were able to get deeper into specifics around the neurocognitive state of the patient prior to surgery. And again, many months later, when we did the factor analysis, we continued to see how important the pre-op neurocognitive state of the patient was. And so then, about 5 years ago, we began to implement a process improvement that included prehabilitation, including cognitive therapy to induce neural rewiring in the brain to help reverse the negative brain wiring that the patient brought into the process. And in doing that, we saw some improvement in our results. This is chronic pain patients undergoing mesh removal, neurolysis, neurectomy in an attempt to improve pain. And the orange bar shows after the prehabilitation and the cognitive therapy, and we're able to see an improvement in our patient outcomes. And we certainly continue to have an opportunity to do better. But these kinds of systems and data science processes are not in place in healthcare yet. So how do we decide between a mesh and non-mesh repair today? Well, we really need to engage a patient and go through a shared decision process. You know, many decades ago, it was always whatever the doctor says, that's what you do. More recently, I think with patient-centered care, we got a little off track and just let the patient decide. In some situations, the insurance companies decide. I think what we really need to recognize is we really don't know for sure what's best, but only through an engagement with our patient, we can hopefully understand what might be the best for them at that moment in time. So part of our shared decision process has been identifying a patient's goals and fears. For example, if a patient is very afraid of having a foreign body implanted in them, maybe consider a non-mesh repair. If they're very afraid of having a recurrent hernia, I would definitely guide them to a mesh repair. And along those lines, talk to patients about mesh-related complications, some of the other factors, whether they're allergic or react to plastics or jewelry or things like that, assess some degree of their anxiety and whether preoperative rehabilitation and cognitive therapy could be helpful. And ultimately, discuss the variety of options, including watchful waiting, minimally invasive versus open, types of mesh. We even had a mesh booklet where if the patient wanted, we would let them see the mesh, feel the mesh, different types of mesh. But it's important if a decision is made that a patient does desire a non-mesh repair, it's important that they understand the trade-offs. There are trade-offs, mesh or non-mesh, and they have to be okay with an open groin incision. They need to be okay with what's probably a higher recurrence rate and a higher likelihood they'll get another hernia. They have to understand the surgeon needs to be comfortable with doing a non-mesh repair. Not every surgeon is. And they need to be okay with limitations that may last longer and pain or discomfort that may last longer than mesh repairs, especially a minimally invasive mesh repair. Now, that's today. The good news is the future is going to move away from reductionist science tools where we really don't get the optimal variety of treatments for different subpopulations. We only get a one-size-fits-all, which is a mess. But the 21st Century Cures Law mandates that the FDA move away from reductionist tools like prospective randomized controlled trials and adapt and adopt a complex adaptive method with real-world evidence, which is what I'm talking about. So the future is going to be bright for this. I'd like to summarize about how we're doing data in a reductionist way in healthcare, and that we need to move away from that, and how we can apply systems and data science into healthcare. We need to stop doing the reductionist model where we don't get improvement and we have a lot of harm and waste. Some of the concepts, the problems with the way we're doing data in healthcare is centralizing data like in registries and EMRs. We get averages. And like I told you with the US Air Force example, averages don't give you insight. And most importantly, the most important thing to measure is the value of care in the context of the whole definable patient process. We're not doing that in our current data management in healthcare. We also do a lot of measuring of processes like antibiotics before cut time, before surgical incision. And we need to be measuring outcomes, especially value-based outcomes. I see continuous improvement models in healthcare applied only to sub-processes like central line infectious or sepsis. We need to understand that that leads to sub-optimization, which means you can optimize the sub-process, but you will not be optimizing the whole patient process, and you will likely have unintended consequences. The other thing that we're not doing is really learning to work in teams with multiple perspectives, and I think that's going to be a tool for the future of improving healthcare. A couple last examples. This is Howard Moskowitz, a neurophysicist, and his story is told by Malcolm Gladwell in a TED Talk about spaghetti sauce and other consumer foods, because the consumer food industry hired him to be a data scientist, to crunch numbers to try to get the best taste of a new product that would sell the most. And so he would do taste tests for something like what percent of artificial sweetener should be put in a diet soft drink. And he would do 7%, 10%, 15%, and try to crunch the numbers for thousands of taste tests and try to fit it on a two-dimensional curve. And he could never fit it on that two-dimensional curve because people don't live in one best taste. They live in taste clusters. And so he understood finally that you need to design optimal differences, optimal varieties of products to address the different taste clusters. Interestingly, data science has been applied in other industries, including baseball, famously in the movie and the book called Moneyball. And in the July issue of General Surgery News, I write about this and why, what it was like for baseball to incorporate data science and why we haven't yet in healthcare, but we will soon. So the new paradigm, how do we do data science in a data and system science way? Well, first step is decentralize data into context in each local environment. And then with multidisciplinary teams, interact with that data, learn from that data, get feedback loops and gain insight, and then apply that new knowledge to improve measurement and outcomes. But the algorithms that are generated will never be perfect, so we always will have to collaborate in a shared decision process with our patient. And then most importantly is measuring value and transparently showing that value measurement and learning from it and networking that learning with other programs. So in conclusion, I want to say, I think we need to go away from the concept of reductionist science from the Renaissance, where Descartes described the human body as a machine, a static mechanical organism, and realize that we're all complex adaptive systems constantly changing. But what this does, this understanding of this science, allows us to deal with this increasing pace of change, because we can't stop the fact that our universe is expanding at an accelerating rate. That we can't change. But what we can do is apply a science that accommodates that increasing pace of change. And when we do, we'll be able to understand optimal variety. We'll be able to lower costs, improve outcomes, and have a sustainable healthcare system. And I think that'll lead to a better world. Thank you very much.